At this point, it's my real pleasure to introduce the new University of Pittsburgh medical history librarian, Cassie Nespor, who started her position in August and follows in C.F. Reynolds' footsteps. Her photo and contact information are on the slide, and she is excited to work with you on research or teaching. If you haven't already come down to the lower floor of Falk Library in the new part of Scaife Medical Building, you should come to look at the display. There's currently up some of the real medical history treasures, the books from and objects from the library, as well as a selection of scope and scalpel posters. But that'll be coming down in a couple of weeks, so don't miss your chance to see that. Welcome, Cassie. We also want to welcome all of the students who are joining us tonight. We invite you to drop the name of your institution in the chat as an optional sort of roll call, but also a chance to represent your school. If you are a Pitt undergraduate looking for catalog of opportunity credit, here is the slide to log your attendance. And when I get a chance, I will drop the direct catalog of opportunity link into the chat. All of the Reynolds Society officers are volunteers, but we do need money to pay our speakers an honorarium for their time and expertise, and to print and mail the annual flyer, as well as for occasional expenses. Dues can be paid online via Venmo or Square, or via snail mail check to our treasurer, Adam Davis, who couldn't be with us tonight because he's teaching at CCAC. If you're unsure whether you have already paid your dues this calendar year, simply email us at cfreynoldsmhs@gmail.com to inquire, and I'm happy to check our records. And then the last announcement is that you should mark your calendars for 7 p.m. on Tuesday, November 11th, 2025, when Professor Alicia Rankin at Tufts University will speak on the skillful surgeon, expertise, authority, and surgical illustrations in late Renaissance Europe. It's going to be a beautifully illustrated lecture, and I encourage you to come to that. So with that, I'm going to invite Dr. Marion Michaels to tell us a little bit about her father, Dr. Michaels, in whom name and memory the lecture is sponsored.
Thank you so much, and welcome everybody. My father, Dr. Milton Michaels, a well-respected Pittsburgh internist specializing in hematology, was born to immigrant parents who encouraged him to enter the field of medicine. But medicine for him was never just a job. It was his passion that he enjoyed for over 50 years. He trained here at the University of Pittsburgh School of Medicine, moved to Boston for training at the Beth Israel, and specialty training in hematology under William Damashek, before returning to Pittsburgh to practice medicine. He was a superior diagnostician and recognized for his compassionate care, his good humor, and constant attention to the medical literature, quoting New England Journal and the Annals and Blood until his last weeks of life at 95 years of age. He was a loyal supporter of John Erland's work for the C.F. Reynolds Medical History Society and a strong advocate for the society as he served as past president. My father had a keen awareness of the importance of remembering where we have been to understand where we are now and imagining where we can go for the future. And he would be particularly honored that today's lecture is on hemophilia. So I, along with my mother, Lois Michaels, my brothers, Eric and Jay, and sister-in-law, Carol, are proud to sponsor this lecture in his memory. Thank you so much.
Thank you. We're really blessed by your generosity. And at this point, I'd like to invite the president of the C.F. Reynolds Medical History Society, Andy Herlick, to unmute himself and introduce tonight's speaker.
Hi, good evening. Welcome to so many individuals who are new. I know that some of our residents in anesthesiology have decided to join and listen to these lectures. Tonight, we are very honored to have Dr. Franklin Bontempo, professor of medicine, who practices classical hematology. After training in Philadelphia and Pittsburgh, and he settled in the Steel City 4 decades ago to specialize in coagulopathy and myeloproliferative disorders. He is the medical director of the Coagulation Laboratory at the Institute for Transfusion Medicine and associate director of the Hemophilia Center of Western Pennsylvania, and serves on the advisory board of the Hemostasis and Vascular Biology Institute. Hemophilia is a genetic bleeding condition that is recognized since ancient times and is perhaps most famous for affecting European royalty descended from Queen Victoria. On a personal note, Dr. Bontempo has rescued more anesthesiologists in the perioperative setting than I can imagine. Personally, he is in times of crisis. Dr. Bontempo was there 24/7 and skillfully managed to get us out of lots of trouble. I am honored to welcome Dr. Bontempo. Thank you.
History of hemophilia, ancient times we go back to. First, we go back to the, actually we go back, well, I think one of my slides doesn't seem to be there. The first slide is from Rabbi Simon ben Gamaliel, who forbade a boy to be, and this is in the first century AD. This slide is a little bit off, I guess, but okay. Who forbade a boy to be circumcised because the sons of his mother's 3 older sisters had died after circumcision. And he lived in the first century AD, and he was the first mention of this ever happening. And in the second century AD, there were Babylonian Talmud writings where cases of excessive bleeding were described in male infants during circumcision also. It was decreed by Rabbi Judah the Patriarch that if a woman lost her first 2 sons after circumcision, she was exempt from the obligation to have the 3rd son circumcised. So let me go 8 centuries ahead. And another Arabian physician named Abu Qasim, otherwise known as Abu Qasis from Cordoba, noted uncontrolled bleeding after injuries in people that and may have been the first to recommend a treatment for it, but we don't know what that was. And then we go a few centuries ahead, 2 more, and the great philosopher and ethicist Maimonides applied a similar rabbinical ruling to the sons of a woman who was married twice, bringing up the idea there may be a difference in women transmitting this disorder. And then it turns out that there is, let me see something here. Well, it seems like, okay, there was an Isaac Zoll from Virginia who exsanguinated at the age of 19. This is in America. And this was published for reasons we don't know in the Salem Gazette in Salem, Massachusetts, even though he was from Virginia. And he was apparently the first American to be known to have hemophilia. And it was listed in an article in an obituary in the Salem Gazette. And if you read it, which is right there, actually, I'm not sure which one you're seeing, but one of his brothers died from a cut on this man had a cut on his foot, but his 5 brothers died of a prick of his finger from a needle when he scraped his face on a stove. Another one had a prick from something else, and all 5 of them died from relatively simple things. And that was the first one reported in America. Now, there was also a person named Kornbrush in Germany who described a bleeding disease that was very similar to hemophilia in 1793 as well. And the next thing was that there was a Joseph. Well, in the case of the guy from 1793, one of the physicians traced back to 1720 and traced all of his descendants from 1720 until the 1793 point, and he was able to document all the hemophiliacs in their family all the way back 80 years prior to that. But then in 1803, Dr. John Conrad Otto, a Philadelphia physician, published a paper identifying an hereditary bleeding disorder noted primarily in males and referred to them as bleeders for the first time. And in 1813, John Hay published a paper in the New England Journal of Medicine, keeping in mind that the New England Journal was only founded 1 year before in 1812 and was called An Account of a Remarkable Hemorrhagic Disposition, proposing that men could pass a trait for a bleeding disorder to their unaffected daughters. And then in 1828, the first term that was ever used to describe a disease was called hemorophilia. It was used by Dr. Johann Lucas Schönlein and his student Friedrich Hoff. And they coined the word from the 2 Greek words for blood and love. and it was later shortened to hemophilia. We're not really sure if it was Friedrich or if it was Johann who did it, because they seem to have some debate about who was going to take credit for it. But needless to say, in 1828, they coined the term first. That's another slide that I don't know how that one got in there. Okay, now we have 3 for him. I don't know. Okay, all right. And there's wow, they're putting all these slides together. Okay, let's take a breath. Now we go to England. And there was a guy named James Blundell who he was an obstetrician, but he performed a bunch of different things. One of them was he performed the first successful human-to-human whole blood transfusion in a terminally ill man. The man eventually died, but his observation was that his pulse got more rapid and he became more pink. And on the following day after he gave him the transfusion, he was able to drink a half a pint of porter. And he thought that was a success, even though he died in another day or so. And this same guy in 1818 as well, using his obstetrics expertise, conducted the first successful human-to-human blood transfusion in a woman who had postpartum hemorrhage, he did this by transfusing blood from her husband through a syringe. And this apparently was another big breakthrough, and it worked out well for him and the patient both. And it looks like we have several versions of my thing in here at once, so just bear with me. In 1835, there's another man named James Wardrop. He was a Scottish surgeon and an ophthalmologist, and he was an associate of Thomas Wakeley, who, with Wardrop, was one of were the founders of the Lancet in 1823. And Wardrop was a surgeon to King George IV, who came after King George III, who we all know about. And he published a long, comprehensive treatise on the blood, which was like 40 pages long. And he suggested that bleeding may be due to defective blood clotting. And he mentioned patients he saw who appeared to have an hereditary disorder of bleeding. Of interest to people who are maybe in ophthalmology, because I come from a family of ophthalmologists, he also was the first person to describe retinoblastoma. Okay, 1840, Samuel Armstrong Lane. Again, along with consultant obstetrician James Blundell at St. Mary's Hospital in London, performed the first successful whole blood transfusion in an attempt to treat hemophilia, one of the earliest ones we've ever heard if anybody had an idea of what to do, just by transfusing blood. He reported in the Lancet that the direct transfusion of 12 ounces of blood from a, quote, stout young woman controlled the bleeding of an 11-year-old boy who bled for 6 days after an operation for squint. And again, bringing up the ophthalmology, in case you don't know what squint is, that's the old-fashioned term for strabismus, or your eyes were not matching each other. And that's he had an operation from that, and he kept on bleeding, and that's how they protected him from the surgery. So now we go up to the early 1800s. We're not there yet. Okay, wait. Well, there seems to be a slide missing here. There's a conglomeration. All right. I can fill you in. I know what happened next. In 1865, Gregor Mendel, an Augustinian monk who came from Brno in what's now Czechoslovakia or thereabouts, published his findings about hybridization of pea plants, which you've all heard about, in 1865, and talked about it in the Augustinian in their society, and published it in 1866. And there's been a lot of discussion about whether he fudged all of his data because it came out too perfect, but things have been held up right to suggest that pretty much the laws of Mendelian inheritance, as we call them, were pretty much set by what he found, because if he fudged it or not, he got it right apparently. But the current things pretty much say that he probably didn't fudge the whole thing. The other thing that came after this, and these many of the things I'm talking about are things that were necessary for the hemophiliacs to get the care that they needed. And the next slide should have been in 1882, a man named Walther Fleming from who was German, a German cytogeneticist, was using aniline dyes to look at cells, and he found that some of the structures inside the cells took up basophilic dyes, and he named them chromatin. And after that, he used other dyes, or other people, or he saw some other structures next to them, and he called those chromosomes because that stood for colored bodies. And he also was the first person to see mitosis, and he named mitosis as well. And now we go to the life expectancy that reached by the early 1900s was still about only 11 to 13 years due to lack of effective treatments and the risk of fatal bleeding episodes. And then, well, this is supposed to be later. I don't know. These slides are a bit jumbled, but bear with me. I can do it. I've done it 3 times already, once for my wife and 3 times for myself. So the first, this is in the later 18, this is before 1900. There's the first report of a woman affected with hemophilia from her first cousin marriage, described by British surgeon and friend of the royalty of Frederick Treves. This case is heavily disputed at the time because they don't believe that it's true, because they didn't think that women could have hemophilia, and was largely dismissed. But reevaluation of the same patient 50 years later proved it to be correct, and he lived from 1853 till 1923. And just to show you how bad things were in 1901, the U.S. Surgeon General's catalog had a list of treatments for hemophilia, and they included administration of lime, inhalation of oxygen, use of thyroid gland or bone marrow, hydrogen peroxide, and also gelatin. Neither of which must have done much because they haven't ever had any beneficial effects that we know of. So then we come to Queen Victoria, who, as you know, lived a long time, 1819 to 1901. She ruled for 63 years, and she reigned for, her reign was from 1837 to 1901, only to be outdone more recently until 2022 by Queen Elizabeth II, who reigned for 70 years, but she didn't have hemophilia. So Victoria, as we've all heard, was a transmitter of hemophilia, and there was no one in her family that had ever had it, in her husband's family or in her family. And Victoria had 5 daughters and 4 sons. But these, her offspring produced 10 hemophiliacs in European royal families, and also 7 hemophilia carrier women. As far as the hemophiliacs were concerned, she produced 1 in Great Britain, 2 in Spain, 1 in Russia, and 6 in Germany. And as a result of this, hemophilia became known as the disease of royalty. Now, as you can see in this chart of their family tree here, here's Queen Victoria, and she had 2 daughters named Princess Alice and Princess Beatrice, and she had a son named Princess Leopold, who was a hemophiliac. And then Princess Alice had 2 carriers, Princess Irene and Princess Alexandria, who became Tsar Nicholas's wife, and a son who was a hemophiliac. And then her granddaughter had Prince Valdemar, who was a hemophiliac, and Prince Heinrich, who was a hemophiliac, and also Alexandra, Tsar Nicholas's wife, produced Alexei, who was the heir to the throne of the Russian monarchy. So Leopold had a daughter who was a carrier, and she gave birth to a hemophiliac here. Princess Beatrice had a daughter who was Victoria, and 2 hemophiliac sons, and Victoria was a carrier, and she became a Catholic, and she married the King of Spain, who had 2 sons, and there was a lot of tension here between the families. And when she had these 2 sons who were, her mother was blamed for this coming from British royalty, and this is at the time of the Spaniards were being challenged by Franco's people, and there's a lot of tension and instability in their family. And this probably in some way led to a certain extent to the entree of Franco into Spain. And by the same token, Alexei's hemophilia was a problem because of the fact that his mother, who was the German woman, didn't have a lot of faith in Russian medicine, but Rasputin came along, and when her son was having a hemophilia hemorrhage, and he had a mesmerizing personality who made his bleeding stop, and he also may have advised not to use aspirin somewhere along the line because he thought it was bad, but nobody knew why. This is a picture of the royal family here with the Tsarina and the Tsar and their 4 daughters, who were called Omtas. They were called Olga, Tatiana, Maria, and Anastasia. They called themselves OTMA, and this is the Tsarevich Alexei over here. And here's the monk who came in upon the family, and he was described by many people, some people, as a man of faith. Other people would call him the man who was crazy. Another person would say he was a man who was evil. And Alexei was the problem because he had repeated hemorrhages. He oftentimes in his pictures would have a cocked right leg because he had a lot of hemophilic arthropathy. And It shows in some of his pictures, and here he is. Here he is at study. But again, a lot of the Russian people hated Rasputin, and they thought that his mother was Alexei's mother was having an affair with him, or he was a terrible person. He started his own religion. I mean, I think he sometimes had to have sex with them to join it, which was an interesting observation. But eventually, it caused a lot of distrust by the Russian people, partly because she was German and partly because of Rasputin. And this certainly has an impact on the fall of the Romanovs after 300 years. Now, this is not supposed to be there. All right. Let's see here what we got. Well, I have to go back. Let me go back a bit. Well, wait a second. All right. This is Carl Landsteiner, who discovered ABO and the ABO and AB blood systems for our red cell types, which he discovered in 1901, which wasn't directly about hemophilia, but it made it easier to know what kind of blood you were transfusing. If you wanted to transfuse a hemophiliac, it was much safer when you could do blood typing, which prior to this time could not be done. And for this, he received the Nobel Prize in Medicine in 1930. And then let's see, we seem to be losing the slide here. Okay. Oh, here, yeah, that's Landsteiner. Okay. Now we go up to a lot of things didn't happen in regard to hemophilia during World War I, but British pathologist Robert McFarland reported in the 30s, 1934, that snake venoms can accelerate the clotting of hemophilic blood, and reported success in controlling superficial hemorrhages in hemophiliacs after topical administration. He was looking for things he could put on superficial wounds that were bleeding to see if he could get them to stop bleeding. But as you know, snake venoms cause problems, and they can cause DIC. That's how it usually kills you. But they actually cause an initial clotting sensation, and then it makes you consumes your blood clotting factors, and then you bleed. And they thought that snake venoms could be beneficial. But from his research at this point, he found topical agents that might have some impact, and led to the Stipfen time and what we call the styptic pen. And when I was younger, when you'd have shaving nicks and you'd cut them, and you had a little aluminum sulfate pen that you would push against your cut, it would make them stop. He was trying to do the same thing. And one of the venoms he used was called Russell Viper venom. And the thing about that, in the coag lab, we continue to use that at the present time as one of the agents we use in making a diagnosis of a lupus anticoagulant. Now, let's see. Then we have 1935, Armin Quick. Armin Quick was a Wisconsin American who was a very industrious academic physician who trained in New York and in Philadelphia. He trained in Philadelphia General, where Osler had been before he went to Hopkins, and that's where I did my physical diagnosis, and it had a huge hospital. But in his time when he was an intern, this is kind of interesting, they had 2-year internships at Philadelphia General that were highly sought after and competed for by a lot of people because they were so good. Although I don't think too many people these days would want to do a 2-year internship if they didn't have to. But what Armin Quick did, he devised the PT test that used to be called the Quick test. And he did this by mixing thromboplastin, which would make the blood clot, and calcium in a test tube. And he momentously found that the test gave a normal result in hemophilia and challenged the long-standing theory of how the blood clotted. Now, at risk of having anybody who hasn't already leave, I'm going to show the coag cascade one time. And I'm going to explain why it is that the PT doesn't help you make a diagnosis of hemophilia, because the PT pathway has these factors, and the factor 7 and the common pathway factors. But as you probably know, hemophilia A and hemophilia B are in the upper part of the intrinsic pathway, which is the PTT part of the pathway. And so a factor 7 level, a PT test will not pick up anything abnormal in hemophiliac, whereas in a PTT test it will. Now, there was supposed to be a slide up here that said hemophilia basics, that said, in case you don't know, hemophilia A is factor 8 deficiency, hemophilia B is factor 9 deficiency, and in the United States today, there are about 33,000 male hemophiliacs. The chance of getting hemophilia is about 1 in 5,000 male births, and the factor 8 deficiency, the hemophilia A is more common than hemophilia B, and hemophilia B is only found in about 1 in 20,000 male births. And the severity of hemophilia is staged based on whether or not what the level of clotting factor you have in the blood. The normal level of clotting factor 8 or 9 is about 100%. If you have more than 5%, you're considered mild. If you have 1 to 5%, you're considered moderate. If you have less than 1%, then you are severe. And there's a tremendous gradation of experience when these levels are present. Severe being obviously a lot worse. But the thing about this is, it brought up the idea that even though it's only about a 5% difference, that makes a difference from going from mild to severe, and that gave people hope to a certain extent. If they could just raise it a little bit, it might make a difference. And in the end, that was sort of found to be true. So the next thing is that in the 30s, 1937. Arthur Paytek and F.H.L. Taylor reported in the Journal of Clinical Investigation that they had identified a substance in normal human plasma that accelerated clotting in hemophiliac blood. Now, this discovery was a crucial step in the understanding of the disorder, as they named this beneficial component anti-hemophilic globulin, or AHG, which contained the clotting, what they called the anti-hemophilic factor, which they isolated in some fashion and was we now know that as factor 8. Also in 1937, it wasn't a big deal, but made things more safe as well. Landsteiner and a guy named Wiener discovered the RH factor on red cells after studying the blood of rhesus monkeys, further making red blood cell transfusions more safe. Now, as we go into the mid-1900s, Argentine physician Alfredo Pavlovsky noted that blood from one hemophilia patient transfused into a second hemophilia patient caused correction of the clotting time and vice versa, suggesting the possibility that 2 types of hemophilia might exist. He couldn't do much more with that, but that's where he left it. And when the second patient's blood was put into the first patient's blood in the test tube, it corrected that as well. So transfusing patient A into B and B into A both cured each other's hemophilia, brought up the idea that maybe there's 2 kinds of hemophilia. And that was further looked at. In 1952, Rosemary Biggs and Robert McFarland found that mixing the blood of a 5-year-old boy with hemophilia with that of a known factor 8 deficient hemophiliac's blood corrected the second boy's thrombin generation time, enabling them to identify their first boy's deficiency as a new clotting factor. And that was true. And the thing about this, which is there's been confusion about this in the past, but I've read about it before. But in the 1952, because the 5-year-old boy's name was Stephen Christmas, and the report on their findings was published in the Christmas edition of the British Medical Journal in 1952, the factor was called Christmas factor, and the disorder was called Christmas disease. And Mr. Christmas lived until 1993, but I don't know what he died from. But I know he lived for a number of years. Also, and that's the picture of all 3 of them. All right. And so in 1958, Swedish physicians advocated for the use of prophylactic use of porcine and bovine animal plasmas to be given before people would get hemorrhages if they were going out and do some activity or whatever. And they suggested the attempt to be used to treat hemophilia patients with that. But when they tried to use the porcine and the bovine animal plasmas, there were often frequent and severe allergic reactions, and as a result of that, their use was limited. However, also in Sweden, she was alive when I was active. Inga Nilsson advocated for regular prophylactic therapy with hemophiliacs with the human anti-hemophilic globulin discovered before, which contained as well plasma-derived factor 8, as well as some fibrinogen as well. And she saw significant clinical improvements in the patients, but prophylactic treatment was not widely used until later years, despite her efforts to show the way for that. In the late 1950s and the early 1960s, fresh frozen plasma, or FFP, was the mainstay of treatment for hemophilia A and B. And since each bag of FFP contained only small amounts of factor 8 or factor 9, it took large volumes of IV administered FFP to stop bleeding, which often required hospitalization. And the whole efforts for hemophiliacs after this were based on the idea of getting an efficient clotting factor that had more bang for the buck as far as the amount of actual factor 8 or factor 9 in a smaller volume of fluid. and something that was going to be safe, and it was going to be convenient to use, and it was going to be low cost. So the goal has also been has always been to efficacy with smaller volumes, safety, and lower cost and convenience. Now, in this case, a lot of the hemophiliacs, I think, in this time had problems because of the fact that younger children who were always instructed to speak up when you had a tingling in your knee for a joint hemorrhage or whatever. A lot of times, I think when they knew they had to go into the hospital and spend a lot of time there and get treated, they wouldn't tell their parents they had something. It was rather cumbersome to do, to give them lots of units of FFP to get a small increase in the clotting factor level. And it took a lot of time to do that, and it wasn't very efficient in doing it overall. But that's where things kind of stood in the 1950s. And then I would also, okay, well, we'll go. 1964. Major breakthrough in 1964 when Judith Graham Poole changed the course of hemophilia treatment, and she was from England, when she reported in Nature that high levels of factor VIII remained in the precipitate formed when plasma was thawed slowly from a temperature of 4 degrees centigrade. This made available for the first time a lower volume blood product that could be stored and made available for emergency and elective surgery as well as prophylactic treatment. And they also, the blood bank started to pull these factors, these cryoprecipitate units. They could take the supernatant off, and they could pull several of these together. And the amount of factor VIII per cc could be 5 or 10 times higher than would be in the FFP that we were using prior to that time. And also, cryoprecipitate was also found to contain von Willebrand's factor, which we're not going to talk about, fibrinogen factor 13, and fibronectin, the opsonizing agent. And so cryo could be used for multiple things, but it's much more convenient. Now, it did have to be thawed, though, which took some time if you were going to treat a hemophilia hemorrhage, they had to be thawed. And you couldn't keep it very well at home, but you could use it to treat von Willebrand's disease, fibrinogen deficiency, and factor 13 deficiency, or if you wanted to get more opsonization of bacteria in people that had sepsis, perhaps. So a bag of cryo would look something like this, and it was much smaller amount of plasma derivative, and it was rich in factor VIII, and the volume may only be 30 or 40 cc's in a bag. Okay, now the next year, in 1965, Baruch Blumberg discovered the Australia antigen for hemophilia B, leading to the development of blood tests for hepatitis. And he also got the Nobel Prize in Physiology and Medicine. I believe it was in 1990 something, 99 maybe. And then in 1968 was the first commercial factor VIII concentrates are developed, where they had were being developed. Also in the 60s, in 1969, a normal dog liver was transplanted into a hemophilic dog with factor VIII deficient hemophilia dog, and corrected the dog's factor VIII levels. Now, I would also say that life expectancy in the late 1960s for hemophiliacs was only about 24 years. Well, I can tell you that going back to the royal family and that I mentioned before, Leopold, and going through the different generations, the upper generation would be Queen Victoria's son, Leopold, died of cerebral hemorrhage at the age of 31. In the German monarchies, that were in the German states at that time, Friedrich, that I pointed out before, died at the age of 3 after he fell through it. He was left alone for a minute, and he fell out through a second floor window. He fell 20 feet, but wasn't injured that much. But because he had hemophilia, he died from a hemophilia hemorrhage. The other Leopold Batten in that same generation died at the age of 32 after he had a hip procedure, and he apparently bled to death. And Prince Maurice, his brother, died at the age of 23 in World War I. I don't know what he was doing in World War I. He may not have known how much hemophilia he had. There's been some debate about whether he really had it, but unless he was mothered by another woman, I don't know how that would happen. He died of a shrapnel from a German shell. And the one who lived the oldest in the royal family was Prince Valdemar, who died at the age of 56 when he had a hemorrhage, and he was fleeing the American oncoming allies. The World War II allies were coming down on his place. He had a hemorrhage, and he kept on trying to escape. So he got a first blood transfusion. He kept on moving, but he couldn't find any other transfusion services. Then he ended up dying because of that. And then the other one in that line is his brother Heinrich. He had a head injury when he fell down from his chair when his mother was approaching him because she had left him alone for a few minutes, and he was playing around on a high table, and he tried to step down and fell off a chair below, hit his head, and he died of a head injury and a hemorrhage. Alexei, we already know, died at the age of 13 in the Romanov in the Russian family because they were all killed in 1918, and he was killed at the age of 13. And Prince Rupert died at the age of 20 of an intracranial hemorrhage after a slight skull fracture after a car accident. He didn't think it was that serious. And the two from the Spanish royal family, the younger one died first at the age of 19 from a car accident. He thought he was okay, but he actually had abdominal bleeding because he must have hit the steering wheel or something, and he died because of that. And his older brother died later, almost the exact same situation. Car accident, didn't get hurt that much, thought he was okay, and died from abdominal bleeding. And I did the math. If you take all their ages and add them up and divide by their number, the average age was 23. And these were the people that had the greatest lives, maybe living somewhat riskily, but they should have had good care. And their average age was about 23. So I thought that was kind of interesting too. And there's another repeat of that slide. Now, why this is happening, I don't know. Okay, let me see. Okay, I don't know. Several lectures are kind of put together that I can do it. Okay. 1970, hemophilia B Leiden, which is the old-fashioned name for Leiden in Holland, was described by Veldkamp in Holland, which is an unusual mutation in the promoter region of factor 9, we now know, which causes hemophilia B in boys, but it disappears in puberty due to the effects of androgens. And I've never seen one of these. They're relatively rare, I think, but they do exist. The next step was trying to get about home treatment, getting treatment into the homes in Germany was reported to be active in 1972. And back in the United States, the Hemophilia Act of 1973 here allowed federally funded comprehensive hemophilia treatment centers to be established. And in 1977, the discovery by Professor Pierre Minucci, who's a fantastic leader in the field of hematology and coagulation, hemophilia, von Willebrand's, discovered desmopressin or DDAVP could be used either intranasally, that should be intranasally, or intravenously, to raise factor VIII levels in hemophilia A patients, only in hemophilia A, not in hemophilia B, because their DDAVP was found to release factor VIII from the endothelial cells in the circulation in the vessels, and to a degree, a therapeutic degree in hemophiliacs, and made it so hemophilia patients without having to get a transfusion of any sort of any blood product in some clinical situations could, and this was another method of treatment, especially for mild patients with hemophilia A. It was a good discovery. In 1980, both factor 7 and factor 9 were confirmed to be on the X chromosome, and the life expectancy of hemophilia had increased to about 60 years. Now, I have to go back. For some reason, I don't understand how these slides are jumbled, but they are. I have to go into the 70s. Okay, 1973, you're not going to be able to see this one. The Hemophilia Center in Western Pennsylvania was established by Jessica Lewis, and she founded the Hemophilia Center. She was married to Jack Myers, and she set for the next 30 or so years, she was the major person that moved hemophilia along, did a lot of research with herself, by herself, and she did a fantastic job of training people and who maybe wouldn't have been interested in coagulation very much, such as myself, to do things they thought they would never do. Now, I don't know where this slide is, but I know that in 1975, the National Hemophilia Foundation, which had been founded in 1948 to promote better hemophilia care by the Henry family, whose son was a hemophiliac. It was begun in 1948, and they went along until 1975, and then in 1975, the Hemophilia Center in New York had very big problems. There were legal problems, public relations problems, financial problems, organizational problems, and governance problems. And he was coaxed along, but there was a relatively well-known in Pittsburgh attorney named G. William Bissell, who was a wonderful person, a friend of the Hemophilia Center in Western Pennsylvania, and a friend of Dr. Lewis's, who was reluctantly agreed to go to New York and try to bail the National Hemophilia Foundation out of its problems, which he was rectified their problems. He did that very well. He got some credit for it, but unfortunately, he's been forgotten about in general terms since that time. But he did a wonderful thing to keep the National Hemophilia Foundation solvent, basically. Okay, now what else do we have here? Okay. 1950s, Graham Pool. Okay. Got that. Okay. I apologize for the jumble. Okay. So here we are, 1980. I'm still a fellow in hematology. Life expectancy for hemophiliacs reaches 60 degrees. And this is when the normal adult male in the 1980s life expectancy was about 77 years. 70, no, actually, that's not 71 years, excuse me, it was 71 years. So in 1981, we get the first formal description of what would become acquired immune deficiency syndrome. It's reported in the CDC, by the CDC in a patient from Los Angeles. This was a non-hemophiliac, however. And the next thing that happened was there was a case of a hemophilia person. No, excuse me. There was 8 cases of Kaposi sarcoma in 1981 that were found in New York by Ken Himes. Now, Ken Himes had found the 8 patients in New York, made this documented that they existed, and thought they had a new disease. But he ended up moving to Pittsburgh to work with Dr. Lewis, and he stayed for 1 year. And he overlapped with me for about a week, for about 2 months before they decided to move back to New York. And so we had the first patient that was a non-hemophiliac that had HIV, or it was then called AIDS, in Los Angeles. And then we had the Kaposi sarcoma patients. And then in 1982 also, the 1982 is when they had the first hemophilia patient was found. And there was a big debate about this time. We already had cryoprecipitate, and they were starting to do concentrates. And the concentrates were made from thousands of donors. And oftentimes they were paid donors as well. And they came from all over the country, including in Los Angeles, New York, and Miami. And they were much more efficient for use because they with a relatively small volume. And it looks like I'm not going to get a picture for this. I apologize for the jumble, but these factors could be moved, could be kept at home in a refrigerator. All you needed to use them was 2 vials, a 10 cc vial of sterile water and a 10 cc vial or so of a lyophilized powder. The concentrates were lyophilized, and they were powders, and you could take some sterile water, put it into the 10 cc vial, draw it up into a syringe, keep it in the refrigerator if you needed to, and then you could inject it into your veins. So even hemophiliacs that were competent enough to give themselves home treatment with factor, whether they were at home or they were on vacation, they could treat a hemorrhage quickly, and they could do it, accurately, and didn't require any thawing. And you can treat a hemophilia hemorrhage faster than you normally could. Unfortunately, you were getting exposed. The number of people that were donating to these concentrates was approximately 5,000. And if any 1 or 2 of them would have HIV in them, they could transmit it to the patients who received that unit of the factor. And these units came from subdivided vats of 5,000 of these 5,000 donors that they would all mix together, and they would get out numerous bottles of factor and send them all over the country. And if anybody had HIV, they would get all those vials could be contaminated. And there were huge discussions about this kind of thing. And some people said, well, these other factors are better, and should we make a decision about clamping down and not using these concentrated clotting factors because they're too risky? But then they would say, but there's only been a couple of cases reported. Should we make a big change all because of this? Now, it's also interesting to note. I have to see if there's a thing about this. Okay, I can go. All right. So what happened was in Pittsburgh, though, there were two centers in the United States. One was the center in Cleveland run by Dr. Oscar Radnoff, and then the other was Dr. Lewis in Pittsburgh. They decided they were uncomfortable back in the 70s. They were uncomfortable, and they said, we're not going to treat anybody with the concentrated blood products when they came out in the early 80s. We're not going to treat them with the concentrated blood products. We're concerned about donor exposures, and they were worried about hepatitis. Now, in those days, we only had non-A, non-B hepatitis, for which we only had a test with the SGPT, which was a surrogate marker. And so if you turned positive with the SGPT for non-A, non-B hepatitis, and you turned positive for hepatitis B, which had been produced by the test for that had already been out. If you were positive for both of them, they decided, we will treat you with the concentrated blood products. And this is before HIV. And in Pittsburgh, they did the same thing. So once you became positive, they would only, before you became positive, they would treat you with cryoprecipitate for the factor VIII deficients, FFP for the factor IX deficients, but they wouldn't give you the concentrates. They made an agreement to do that, and they were somewhat laughed at. They were being they were not up with the times. They should be using the concentrated blood products. They decided not to do that. And the thing that's really amazing is that the second hemophilia center director was Maggie Ragney. And Maggie Ragney and Dr. Lewis, every time the hemophiliacs came in, they would draw their bloods and check them for the hepatitis. And they would keep the plasmas, and they would either decide to put them on the concentrates or keep them on the cryoprecipitate and FFP regimens. But they took those specimens, those plasmas they did the testing on, and they archived them all, and they kept them. And so as time went on, what happened was, in 1983, while they're having this big debate about which was the safest product to use, the FDA approved a new heat treating process to inactivate HIV in the lyophilized freeze-dried concentrates. And this process can't be used for cryoprecipitate in the treatment in hemophilia A or FFP for hemophilia B, because those things had to be frozen, and the concentrates did not have to be frozen. So all of a sudden, around that time, there was a major switch. Everybody went to the inactivated HIV for HIV lyophilized concentrates, which were previously considered bad. But there was a major switch, and Pittsburgh and Cleveland did the same thing. And we probably prevented some people from getting HIV. But then Dr. Ragney and Dr. Lewis, at some point after that, when the HIV test became available, which is a little bit later, they went back into the freezer, they pulled out all those specimens, and they had specimens going back to the early 70s. And they looked at them, and they found out that there was one hemophiliac that we had who was HIV positive in 1977. There were two who were positive in 1979, and there were dozens and dozens of them in 1980 and 81, meaning that even if we had a treatment better or pulled the products off at an earlier phase, hemophilia was already in the blood supply way before we even knew it, which was little consolation. And again, the first HIV infection in a hemophilia B patient was in 1983. And then the next thing that happened is in 1984, the human factor VIII gene was characterized by Gitshire et al. In Nature, it's showing that it was 186,000 base pairs. It's a huge molecule, 26 exons ranging inside from 69 to 306 pairs. Now, the other thing that had happened previously, which is missed in one of the previous slides, was that in 1953, Watson and Crick had already discovered the DNA double helix, and Watson, Crick, and Wilkins shared the Nobel Prize in Medicine for this later on as well. Absent in that award was Rosalind Franklin, who did the X-ray crystallography for them, and she probably died from her exposure that she got from doing X-ray crystallography, and was exposed to large doses of radiation at a time when people weren't protected from it, and she ended up dying at a relatively young age from from ovarian cancer, and she may well have gotten that from what she did, and she didn't get the Nobel Prize for it, in case you're interested. And 1985, the first success, okay, we have to go back a little bit too. In 1984, I think it was, Dr. Starzl tried to do a liver transplant in a hemophiliac who had end-stage liver disease. After Dr. Spiro in our hemophilia center had written the first, page one, the lead article in the New England Journal on asymptomatic structural liver disease, pointing out how many hemophiliacs had pretty severe liver disease and didn't really know it. It wasn't really looked at because he biopsied liver hemophiliacs who had livers that were already affected, and he showed that was a big problem. So Dr. Starzl tried to do a liver transplant in a hemophiliac, and he had been operated on numerous times before, and because of that, he spent hours in the OR and dozens of units of red blood cells, trying 3 times to make the anastomosis. Unfortunately, his the vascular supply to the liver and the portal vein and the upper abdominal vessels was so shortened by previous surgeries, he wasn't able to make the hookup because of that, and the patient sort of died on the table. But in 1985, the first successful liver transplant in a hemophilia patient was done in Pittsburgh, also by Dr. Starzl that night. I was the one who was there for that. We had to get our ACE tech from the lab, came down and stayed up with me all night to do serial testing of the patient's factor VIII levels. We got him up to relatively quickly a high level of factor VIII. He went through the procedure quite well, and he was from Chicago, and he had end-stage liver disease as well. And he started to show. We had to make a decision about, at the end of the procedure, do I keep on giving him clotting factor, because how long will it take until the liver starts to produce factor VIII from the liver? We had a little bit of an idea, but not very much. And Dr. Lewis called me and said, let it go and have George there. George Arve was our tech, and let him do a quick check anytime necessary. Let's just see if it keeps on going up, if it goes up or if it starts to go down quickly. So I crossed my fingers. I didn't cross my fingers, but I said, okay, we did it, and it started to rise almost immediately, and he did well. He didn't require clotting factor anymore. The next thing that happened was AZT was approved for HIV infection. We actually reported the liver transplant in a letter to the editor of the New England Journal, and shortly after that. 1987, AZT was approved for HIV infection, the first real drug treatment for it. Now comes along 1987, a transplant patient comes along for a heart. He had clotted off all his coronary arteries because of the high potency. He had an inhibitor against factor VIII, and he was treated with this high potency factor IX concentrate that was a problem. And he clotted his arteries off in his heart. He was a class 5 cardiac. He was only about 14 years old, and he was taken for a heart transplant. This was the first one ever done. It was complicated by this inhibitor that made the factor VIII not pretty useless. We got his inhibitor down to a relatively low level, and I had to go down to the OR with the surgeons who were really anxious to do this. And I gave him the clotting factor. I had a really difficult time giving large amounts of factor VIII to get his factor VIII level to going from 1% to 2%, which is not an acceptable level for transplant. We try to get him to 100%. And then I had to give him a 4 times normal dose to get it up to 99%, which first I got him up to 19%, and the surgeon took a scalpel and put it to the patient's chest and said, now can I go? And I said, no, you can't. And he has to take a back seat for a while. And I gave him four times more, and I got him up to 99, and he kind of stayed there. I overwhelmed the antibody, and he went through the operation, and he did well. He had some infectious problems post-operatively, but he ended up coming back to Pittsburgh. He went to Duquesne, and he graduated from Duquesne undergrad. So the next thing that happened was in 1987, there were the first clinical trials of recombinant factor VIII in humans began. And next was in 1990. This was the introduction of the first specific test for non-A and non-B hepatitis. And after that, in 1982, was the implementation of the first blood donor testing for HIV-1 and HIV-2 antibodies. And when HIV testing first came out, They primarily used it to screen blood donors, but we were able to screen our hemophiliacs as well. Also in 1992, the first recombinant factor VIII concentrate licensed for use in hemophilia A patients provided a safer alternative to plasma-derived concentrates. And there would be four new four different sequences of continually improving recombinant factor VIII. So we're no longer going to be taking any of our factor VIII supply from the bloodstream anymore. We're making it in the lab. There would be four different generations of these concentrates that came to use at much greater cost. But again, the safety was excellent. The ability to do things quickly was also very good. And that turned things around for the hemophiliacs and to a large degree at that point. In 1997, the first recombinant factor IX concentrate was then approved for use in hemophilia B patients as well. And then in 1996, Dr. Ragney and the Hemophilia Center started to pioneer the use of the highly active retroviral therapy for HIV infection. And in 1997, a recombinant factor 7A, what was licensed for treatment of hemophiliacs that had factor VIII inhibitors, which was the kind of thing that the hemophilia heart transplant patient had. In 1999, implemented was the nucleic acid testing in blood donors to directly detect genetic materials from HIV and HCV in the window period prior to the early phase of detection. There was a lot of concern that our HCV and HIV tests were not accurate immediately after the person contracted it. And in the window period where the person may not turn positive with the older tests, they weren't good enough. But when nucleic acid testing got started, it made things much better as far as being able to make it so people couldn't slip through with HIV when they were donating blood. And then we go to the 2000s, when the safety and immunogenicity of subcutaneous hepatitis A vaccine was shown to be beneficial in children with hemophilia, which was published in the Journal of Hemophilia and was led by a team of people by Dr. Ragney once again, who again became the second director of the Hemophilia Center after Dr. Lewis. In 2009, there was a report in blood of a mild hemophilia A donor liver who was given to a patient with alcoholic cirrhosis. Now, we're not sure how this happened. Apparently, the patient may not have known he had hemophilia, but they did give a hemophilia A donor liver to a patient, and the patient had alcoholic cirrhosis and hepatocellular carcinoma. But after the liver was donated, he maintained a normal level of factor VIII afterwards, after the procedure, which kind of confirmed the fact that factor VIII was not coming just from the liver, because we didn't know when I did helped them do the first hemophilia transplant with hemophilia A, we knew that it showed that the liver produced factor VIII, but we didn't know if it excluded extrahepatic production. And this 2009 patient proved that there was extrahepatic production as well, that they went well above what the donor liver was able to produce. The other thing was that there's Watson and Crick. I hold on him now. Okay. The other thing was in 2009, DNA analysis confirmed that Queen Victoria was a carrier of a point mutation on the factor IX gene, telling us that Queen Victoria had hemophilia B. It was probably of a spontaneous mutation in her, or it could have been in a spontaneous mutation in the sperm of her husband. It was located on the X chromosome, and that also what was found was the body of Anastasia, the daughter of Nicholas II, and also of Alexei. Their bodies were found, and they tested them, and they found out that Anastasia was the only one of the four daughters that had hemophilia B. And they could have, perhaps, if they would have known that the other three daughters didn't, they were concerned about them getting married and then producing more hemophiliacs. If they had known that the older three daughters didn't have any hemophilia, they may have been able to marry one of them off, and that may have protected them to a certain extent against getting killed, but that's not necessarily true. And the other thing is that it was found that Alexei definitely had hemophilia as well. Okay, so then the next thing is, oh, here we are. We're going backwards again. Okay, I don't know how that happened. But there's Watson and Crick. I already said it. There's a report in 2020 in the American Journal of Medicine that hemophilia B acquired by a patient who received a liver from a mild hemophilia B donor. The other thing was, let's see what we got here. Well, there's gene therapy as well. I don't know if the gene therapy made it. Okay. What was found in gene therapy was this. Gene therapy trials began at a certain point. I forget the date, but let me see if I can find it here. I'm not going to find. Okay, gene therapy trials were approved first for hemophilia B. The reason the hemophilia B was chosen first is because the molecule was smaller, and the hemophilia gene was cloned first by Chu and Karachi and another. There were two different papers that did it 2 years before the factor VIII. The gene was cloned by Gitshire, as mentioned before, and the hemophilia B molecule is a lot smaller. It's about 4 or 5 times smaller than the hemophilia A gene. It's easier to work with. And first they tried hemophilia gene trials with AAV vectors, and they were able to get hemophilia B levels to go up a little bit. And the long story short is that they were able to get the goal was to actually replace the gene with something better, and to get around having to use clotting factor to do things, and it's replace the gene. They tried the adenovirus associated vectors, and they would raise factor levels to a small degree, but they can never be done that well. And so what they did was they started to use other viruses, and they're trying to use gene editing techniques like CRISPR, which is currently the wave of the future. And they're also trying to use the vector of the lentivirus instead of the adeno-associated virus. And so in the earlier trials, they were able to get the hemophilia levels up to about 30% in a few patients, but not in all of them. And they're hopeful that the CRISPR technology and the editing functions of these new technologies may be able to actually cure hemophilia in a short number of years. The last thing I would mention is that the efforts have been spurred recently, probably appropriately, to focus more on female carriers of hemophilia with milder bleeding symptoms, which have gotten short shrift and less attention in general for the last bunch of years. And we have found among the Amish population, which have a relatively inbred society where we have women who have two factor X chromosomes that are positive for hemophilia B, and they actually act like hemophiliacs. They're relatively rare, but they occur. But as more research and more looking at this, we've been able to show that a lot of women that have even carriers for hemophilia have heavier menstrual bleeding, and they have joint hemorrhages occasionally as well. And there's been a shifting in focus to looking to try to get more female carriers of hemophilia to come in to be evaluated and taken care of. So I have to apologize. These slides were jumbled and a few of them are missing. I did the best I could from memory. I will supply the list that was supposed to be supplied of the slides. If you have any questions, I'll be happy to answer them if you would like me to.
Thank you, Dr. Bontempo, for an incredible journey across thousands of years. Because it's relatively late, we like to keep the questions to relatively small number. Please raise your hand in the chat if you would like to. Otherwise, I will take it as they come if you raise your hand. Please raise your hand if you have any questions.
Well, I would say this one thing. Can you still hear me okay?
Sure, Frank.
Well, you notice that a couple hundred years go by before anything happened in the early days, and then it got to be every couple of decades. Also, one of the slides was missing there. Let's see, I have to say one more thing. The other thing that happened was that the life expectancy, about 5,000 hemophiliacs died during the 80s, and from HIV infection. And the life expectancy, which had almost reached normal at the beginning of the beginning of the 80s, fell back to we lost 15 years of life expectancy. And currently, I did mention in one of the slides that didn't make it apparently, was that the male hemophiliacs now live to about the same age as non-hemophilic males. But you see how rapidly things have changed in the last 5 or 6 years. I mean, or 10 years, and the continued increase in the speed of discoveries is very gratifying to see and hard to leave it. And we hope that in the near future, these CRISPR technologies, whatever, will be able to edit the genes for not just hemophilia, but for a lot of things. And that makes it kind of nice to be alive if you're in medicine at this point and try to be a part of these things that are happening, not just in hemophilia, but in all kinds of things. That would be my final comment, I suppose.
Thank you very much for gracing us with your career's worth of experience for an important topic. It looks like Dr. Yost has a question that I may invite him to email to you because it is getting on 8:30 and we want to respect everybody's time.
I
So
appreciate it.
thank you so much again. And we hope that everybody will come back on November 11th to hear about early modern surgery.
Thank you, Dr. Bontempo.